Fiona has worked in critical care for 30 years as a bedside nurse and most recently as a clinical nurse specialist since 2007. She practices as an advanced practice provider for critical care medicine and has helped redesign the resuscitation program at Ochsner Medical Center in New Orleans. So without any further ado, Fiona, I'll go ahead and pass it over to you. And thanks again for joining us today.
Great, thank you. Thank you, everyone. We are going to go over a little bit of review of what our program is and how we do debriefing. So I'm excited to share that with you. Just quickly, some disclosure. I don't have any disclosures except for that I work at Ochsner Medical Center, and these are my views and my opinions. So our objectives today are to go over hot and cold debriefing very briefly, discuss best practices in cardiac arrest and kind of how we built our program, share our journey, and then really look at using a scorecard for debriefing, which will take up most of the presentation, and then just some challenges, and then hopefully to answer some of your questions, which is the most important part. So quickly to review, this is just the recommendations from the American Heart Association. I'm sure you're all aware that they came out this year, 2020, just a month ago. And so I took what I thought was important just to look at the recommendations and kind of align them with our approach. I thought that would be an easy way to kind of work through the presentation and just talk about some of the clinical strategies, interventions, treatments, and diagnostics. And so some of these images will be very familiar to you if you've been doing resuscitation for any period of time. This is really the Epstein formula for survival. And what we chose to focus on was really teamwork training, in situ education, and CPR using feedback devices. And so that's one of the things, this is kind of what we'll talk about a little bit today. So if we look at the chain of survival, we actually started way over here on the left with the early recognition and prevention, because obviously we want to prevent cardiac arrest if we can at all. We really focused a lot on our rapid response and emergency response teams. And then we were lucky to have some new high quality CPR feedback equipment that we were able to use in conjunction with our teams. So we'll talk about that a little bit too. Just to review debriefing, briefing is a process of reviewing and communicating pertinent facts about a resuscitation before the event. Debriefing is after the event with 2 or more individuals. There is hot debriefing, which occurs in minutes to hours after the event, and cold debriefing, which is days to weeks following. Hot debriefs, these are some of the ones I took from the AHA website, which are really kind of a plus delta, how do things go? And then some of them are a little bit more detailed than others. Here's another couple of different ones. We use something more like this hot debrief, which is what went well, what do we need to improve, and what immediate actions need to be taken. So we do a very fast hot debrief at the end of a code, whereas some can look much more in depth like this, but we use that really for later. Just in terms of how we set up our program, we really focused on early warning systems. And so this is just the recommendations from the AHA from the 2020 guidelines. Instead of trying to teach 10,000 people how to do CPR, we really chose 50 and we trained them very, very well. And so all of our cardiac arrests, and they also help review with us. Then in terms of, we really feel like the rapid response nurses are our team leaders for our resuscitation events. So what we did was we trained our nurses very well in how to conduct a code, and then also how to make sure that we were doing targeted resuscitation, and then they could help guide the other staff. And then in 2019, I'm sorry, we did start to teach all of the rest of the staff in the hospital the same techniques, but we started with the rapid response team. And then in the last year, even with COVID, we've managed to focus on debriefing. And it's really the cold debriefing that we've done more work on, because we found that that's been more effective, particularly with our climate. It's very difficult to do hot debriefing and with any level of anything that's really in depth. So we've really focused on the cold debriefing. So that's what I'm going to talk about today with some of the technology that we have. So CPR feedback, again, is in the guidelines, and you can see that a lot of these guidelines have weak recommendations with low certainty of evidence, which that's really incumbent on us to try and show that this works. And hopefully I'll be able to show that to you today, that this technology can really help us improve. And this is an example of, if you're not familiar with the devices, this is an example of our actual device. So this is what we would use during a, well, obviously a person, but this is the technology that we would use. And then this was our code review that we used initially, and now we use case review. So I'll show you that too. So in terms of cold debriefings, we do them within 72 hours. So everybody enters in, our rapid response team enters in a code review within 72 hours into our occurrence system, our occurrence reporting system. In two ways that's helpful. One, anything that's really important that needs to go to leadership safety huddles is escalated within 72 hours. And the other thing is that we have unvalidated data in our medical records that will disappear after 72 hours. So in order for us to really get a good view of exactly what happened in the code, we review within 72 hours. And then on the clinical side for the actual clinicians, we really need to get to them before 72 hours to make sure that the memory, we capture all the memory of the event. So that's kind of where we started. We do a weekly case review. So every Tuesday at 4 o'clock we meet, so everybody knows that that's what the time and date is. We actually have a call right before our 4 o'clock call. At 3 o'clock we meet with our Zoll data clinician who helps us with any data, any questions we have, anything that we want to input into our case review program. We then we review the actual Zoll data on that call, and that's what I'm going to show you in a minute. And then we review the cases after that from the clinical side, and the clinical teams present their case reviews so that the nurses on the floor, or the managers or respiratory, whoever was involved, they bring their cases and they've done their kind of deep dive into the code. And then we, on the critical care side or the response team, share our work, and then we really track and trend all our action items from there. So I'm going to just show you a way that we look at the first part of our session, which is going through our data and quality metrics. This is what the first screen of our case review looks like. We can analyze our compression fractions, so our depth and speed of compression throughout the code. We can look at what time we turned on the devices. We can look at when the pads were on and the total time of the CPR, and look to see if we had shocks. The next screen looks a little bit like this, just to help orient you. So one of the other things we're looking for is, do we have a lot of pauses during the CPR time? And so this gives us that in a very pretty view. So we can see exactly what happens. It gives us our pre and post shock pauses also, because our whole goal is to have hands on the chest for as much of the code as possible. So this looks very busy, but I'm going to try and orient you to the slide. This top bar gives us our cardiac arrest or CPR event summary. It tells us when CPR was happening, and here you can see where it stopped. The CPR period, you can see we have a little gauge up here that gives you that information, so we don't have to search for it somewhere else. This is actually a case that I sent back to our team that says, great job getting the pads on. What we do is we compare what time did our code pager go off, And then what time did the pads get on the patient's chest? So just starting there was great job. It was almost simultaneous, which that was not where we started. We started with very big deltas between the time of the call and the time the pads were on the chest. So the staff are doing a great job getting the pads on the chest and turning the defibrillator on. Because if you don't turn the defibrillator on, we don't get any data. So they're doing a great job with that. This gives us our depth of compression through the code. This gives us our speed or rate of compression, and we're looking to be in this blue bar right here. Oftentimes you can see when people are getting tired because their depth is less and their speed is more. And then here is our depth. And then at the bottom here, we can look and see our end tidal CO2. So that gives us some information on the code about what happened. So just even looking at this and not even knowing, not even being present at the code, we can see that we did a great job starting CPR. We can see we gave one shock in the code. We have this time where we don't really know why this CPR was stopped. Our assumption is that we got ROSC for some period of time. And then we must have restarted CPR because we lost ROSC. And that is further validated by this end tidal CO2, which is running about 30, which is what we would expect in a resuscitated patient or with great CPR. And then where we drop off here, we must have realized that we lost ROSC and then we restarted CPR. So that's, again, just from looking at this data. The second thing we can look at is we can actually do a playback of a rhythm to see what happened and what our opportunities perhaps were. So this is where I clicked into the rhythm and where our CPR was happening. So at the top, it tells you here, it's got the little data to tell you what period is which. And so this is where I'm clicking into our playback and I can actually see the cardiac rhythms. So this is an EKG, but it is where we would be doing CPR. So it looks a little bit abnormal and abstract. But if you can see here, it says filtered EKG, which means it's not giving me that interference. It's giving me what the underlying rhythm of the patient actually was. And then at the bottom, I have another click box where I can select CPR. And these are interchangeable, so I can change many things on these bottom graphs. But what's important on this particular one is, again, I wasn't in the room, so I don't know what was happening, except for if I'm clicking at the beginning of the code here, this looks an awful lot like ventricular fibrillation, which leads me to believe that we could potentially have defibrillated the patient here. And as we know, with Get With the Guidelines, we want to defibrillate within 2 minutes. So we had an opportunity perhaps here to have defibrillated sooner. Now, again, I'm not there, so I don't know, but when I did go back and ask the staff, they actually asked me, we think we might have been able to defibrillate earlier. Can you look at the strip and go see? And I said, yeah, you probably could have. What was happening, and they were actually trying to intubate the patient here. So again, it tells us two-way communication if they were asking a question and we were providing an answer. So this is a little bit further along in the same rhythm strip where I clicked into the rhythm. It shows me that we're in VF here. And again, we still didn't shock until a few seconds later. Actually minutes later on this one. So this is where we shocked. And then you can see, again, it's just a different view of the same patient. But now I'm looking, I changed the bottom screen so I could look at the ventilation performance. And this is where I was trying to show how this little bar, you can see, you can look at the pause periods, the ROSC, the CO2. And so the yellow is the CPR period. The blue is compressions. The red is end tidal CO2. So this tells you when this was on or off the patient. And then of course, this is where we can select whether we have an EKG, filtered EKG, CPR, end-tidal CO2. I can interchange these buttons to get which piece of information I want to get. Again, a similar presentation, so similar orientation. You have the same bar at the top. So now I've moved to the end of the CPR period, and now I'm moving into I have an end-tidal CO2. I don't have CPR happening here. And so when you look and see, why do I not have CPR happening here? Well, it looks like I have a rhythm. So I'm not in the room, so I don't know if this is PEA or if it's an actual rhythm. But when I look at the end-tidal CO2, it would lead me to believe that if I don't have compressions, I have something that looks like a rhythm, and I have an end-tidal CO2, I have ROSC. So I can tell that just by looking at this graphic output. And then moving a little bit later to where I lose my end-tidal CO2, the staff wouldn't have known that unless they were directly looking at the defibrillator for that information. And usually we have a staff nurse, one of our rapid response nurses is kind of being the coach from the defibrillator. So I have no end-tidal CO2. So now they're going to look for a pulse, because we tell them, look for a pulse if you don't see an end-tidal CO2. So they're going to look for a pulse. They're going to see a rhythm, but now they've gone from a perfusing rhythm to a non-perfusing rhythm, and they restart CPR. And this is kind of a similar view of that same rhythm. CPR stopped, no end-tidal CO2, restart CPR. And right here, it shows you that you can change here. I can change it from EKG, end-tidal CO2, whichever one I want to put in this area. And again, similar pictures of the same thing, just in shown in different ways with different filters on the bottom of the EKG. So that's one event, and I'm going to move to another event so I can show you a few other features that we have. This one is a case that we actually annotated. So same layout, CPR here. We've got rate and depth pretty much in target in these areas along this blue line. We have a release velocity, which is when you're, obviously lifting up your hand to make sure that you get recoil off the chest. We have our end-tidal CO2, and our end-tidal CO2 is right at 30. We have our compression fraction, which on this patient was 100%, and CPR pauses, there were no CPR pauses on this one. And part of the reason for that is that we annotated it. So I'll show you how we did that. So this is great if you're trying to give feedback perhaps to somebody who's not at one of our meetings, or you're sending it by email, so there's not always two-way communication about the events. This is where the nurses figured out that there was a problem with the patient. You can see that we actually have a rhythm, and we see, this is the beginning of the code, we see that they must have still been seeing a rhythm if they were at the patient's bedside. But we've taught the staff, if the patient is agonally breathing or looks like they're about to code, meaning that they barely have a pulse or they're checking for a pulse, to start CPR, which is exactly what they did. They saw a rhythm, they started CPR, because that's what all this interference is. You can see the numbers underneath that show our CPR depth and speed of compression. And then what we actually did was here, we actually made this patient comfort care in the middle of this, and we blocked off our periods of discussion or our periods of ROSC. So we annotated it here to block out this CPR time where there was no CPR. Let me flip to the next one so you can see it a little bit better. We also marked it here in our actual data, we actually put data points that you can add when you're clicking into these rhythm strips. You can see the CPR period. We can edit these. We can edit the start and end times on these data strips so that if there are periods where the patient shouldn't have got CPR and we want to annotate it, we can. And so same thing here, you can see where we stopped CPR. There was some kind of a rhythm. And during this period of time was where we started having conversations with family members. We then, if you go further into the rhythm strip, you can see the same thing. The rhythm is changing, but it potentially could be a perfusing rhythm. If you're at the bedside, you may feel a pulse. And then here you can see where we start losing the end tidal CO2. So you can start to map out, depending on where you are in the patient's journey across their CPR episode, you can map that out and see where the patient was likely had some ROSC or did not, so return of spontaneous circulation. And then here, this is where we chose not to restart CPR, but the patient was still alive for a little while, so we were able to have the family come in and be with the patient. So just to summarize, the things that we present to our code teams, we have our code review weekly, and then we have a code committee that we present to, or we actually call it resuscitation because we do rapid response and codes. So the data that we present are the number of codes, the return of spontaneous circulation, how many patients we discharged alive. We actually look at whether they got ROSC and went to the unit, and if they were discharged alive or expired. We look at some trend reports, which I'm about to show you in a second, that we can move from our defibrillators. We can look at from our defibrillators, and then we can look at our individual patient events. So this is really helpful to drive change and improvement on the units. So quickly, I'll show you. This is not our data, but it is some aggregate data that shows you how you can summarize what's happening on all of the units in your hospital. We can break down here down to individual units, and actually within this case review, we can tag things for if there's different types of events, different filters and tags we want to put on things, we can put that over here in this session. We can present data like this in this way just to look at compressions, whether they're in target or not in target. And so we're saying that we want our target compressions to be above 60% on this one. The peri-shock pause times, we want to try and keep our seconds less than 10. On this one, we have it set at 5, less than 5 seconds. So pre-shock and post-shock, so that's the time off the chest. And so really, we're just trying to use all of this data to improve our practice at the bedside. We're trying to use the guidelines the AHA has set out for us. We're trying to make sure that we're culturally aware of what happens within individual units and really their patient populations, because they're very different. A liver unit doesn't look the same as a cardiac unit or perhaps a med-surg medical unit. We're trying to maximize our resources as best we can. So we're we're utilizing everything the maximum that we can. We want to track and trend the data so we can measure it and give feedback to staff and leaders so we can look at what other needs we have. We want to continuously evaluate what we do, and we want to make sure that we share that with the staff and get their input of what things we can improve on. And then obviously celebrate what we do well. And one of the things we've done really well here is move our, time to get the pads on the chest. We've moved that incredibly in the past 6 to 8 months. So hopefully that gives you kind of a summary and leaves us with some time to ask some questions. Thank you very much for your attention.
Terrific. Fiona, thank you so very much. That was a great presentation. There's a lot of really cool points in there, and I like how the one slide you had that showed you know, there's a slide on the lobby and the different areas and how you break it down to that level of detail. I think that's terrific, and that will just really help drive better performance over time, I could imagine. So great presentation. Again, we thank you very much. So to the group listening in today, as I mentioned earlier, if you could go ahead and please enter your questions in the Q&A icon down towards the bottom, and we will get them asked and answered. Fiona, if you would mind, if you could stop sharing your presentation, and then let's get rolling with the questions. So the first question that has come out is, so, you know, in terms of if an institution wants to start debriefing on cardiac arrests, right? Everybody has to start from somewhere. What's your advice on how they can start that process to debrief as a group?
I think you have to get everybody on the same page and understand what debriefing means, because it means different things to different people. You have to have people that can be trained in debriefing. I don't think you can just start with staff that are novices, and it doesn't take many people, but I think that particularly hot debriefing, it's a very heated, emotionally charged environment. And so providing the wrong feedback in that situation is not desirable. So what we actually try and do is, obviously we do something quickly in the moment, just specifically for things that need to be addressed early. And then what we've tried to do is set up this process of the cold debriefing, just so that we can try, and what we do is we meet together. And at first it was really just our team, like our response team that came, which doesn't give you all of the information that you need, because there's a whole nother side of what happened. Obviously, we started with our ICU nurses, our rapid response team, and then our floor nurses. So now we actually have them present the cases. So they come and they present their cases. They do a deep dive into what happened from their perspective. Perhaps they had two things happening at the same time, two emergencies. You know, you often find things like that with their staffing. And so we developed a review tool that was helpful to both sides, so we could start to track that. So I think it's going to be different for everywhere, but that's what we did.
That's great. Thank you for sharing. So this next question goes into you mentioned during a hot debrief, it can be very heated, very emotional, lots of adrenaline flowing after something like that. So this question has to do with kind of the emotional feedback aspect of it. This comes from Tara White from Temple. So she says, congrats on a great program. Have you considered including the emotional feedback aspect of debriefing in your hot or cold debriefs, either one?
So we actually try and do what's called a pause, and you'll see that in the literature in a lot of places. And it's basically, if the code ends in the room, then we try and stop for a second. And it's really has to be, we've tried it with the chaplain, we've tried it with different people, but it really has to be the person that's running the code. And we try and stop and say, okay, everybody, thank you for your time. Thank you for the patient. You know, we try and make it not really denominational. It's very non-denominational, and just say, you know, thank you for everybody's hard work. And that sets an emotional tone. Just, it takes 3 seconds, but it's thanking everybody for being there, thanking for the hard work, respecting the patient that tried to serve. And so that then we can kind of go through okay, what could we have done better? You know, it's a little bit more challenging when the patient is moving to another unit.
Sure.
Because there's a lot of, you know, it's a lot more chaotic at that time because there's a lot of happening. So trying to keep hold of the room is very difficult.
I'm sure.
But how we did it. So that's how and I'm sure there are better ways to do that, but that's a way that we tried to deal with the emotional part.
Yeah, that's really, I mean, it's really hard, right? That's got to be a very difficult part to manage post arrest. So hats off to you guys for figuring out a way to at least kind of, like you said, pause and give people a second to kind of pay those respects. So, this kind of goes back to one of the first questions. What were some of the main challenges you had to really overcome, if you will, when you were implementing debriefing as a whole, whether that be with staff, getting the data itself, whatever that may be? What were some of your main challenges?
Yeah, I think that's part of it, right? It's part of, you have to figure out what data do you have, where do you have it, who's the team that's responding, who's going to be available to do debriefing. So we started off, as I said, with our rapid response team, because our rapid response team it's a team, but it's a team of ICU nurses that are spread from different units. So some from our neuro unit, some from our cardiac unit, some from our medical unit. They are drafted in, and it used to be that we had a consult type service, but this is their job of the day. They come in, they're not an ICU nurse with an extra job of running to the floor. This is their job for the day, is to go to proactive round, to go to rapid responses, to go to cardiac arrest. And we have quarterly training to train them on all the things we really want them to do. Mm-hmm. So, they're the best people to give you the feedback on what works and what doesn't work. And so we've had, obviously, defibrillators for a long time. We got new defibrillators 2 years ago. We had some in the ICU, but not on the floors. So we trained them how to use it, because they weren't even using the equipment that they had when we didn't have CPR feedback. So, and then what is your priority? Your priority is CPR. So start CPR. And it's simple. Keep it simple.
Great.
Answer the question?
It does. Yes. Thank you. Thank you very much. So that's a good question. So you said you have about 50 code team members. I've been to Oshner before. Obviously, that's a large facility. Out of how many, how many nurses and units do you have in the hospital? So this is coming from someone, it appears, that is in a smaller community hospital. So how would you kind of help and suggest developing a team in a smaller facility?
Yeah, so it's actually a really interesting question, because we were able to do that in a big academic facility. I mean, not huge, but we have about 600 beds. And so when I say we have 50 people trained, it's because they substitute for each other. I'd love to have 20 people that just did that full time, but we don't. So we interchange our 50 people 24/7. So that's what we do with those. But what we did at one of our community facilities, and we're trying to kind of play this out in some of our other facilities, is they did use their ICU nurses. And actually, they started this in COVID, which is actually amazing that you would do this initiative in the middle of COVID.
Right.
But they actually, they actually started their rapid response and resuscitation program right in the middle of COVID. And they were able to do it. They were able to show they actually decreased their cardiac arrests to, I think they had in the since April is when they started it, I think they've had one cardiac arrest.
Wow.
Actually had to.
That's amazing.
Yeah, it's great. We dropped our cardiac arrests by about 70% with our program overall. It just adds another layer to it. Obviously, we just keep adding more layers. But in the first year, we dropped our cardiac arrests outside the ICU by 70% and inside the ICU by 30%. And they've seen similar things. So it can be done. You just utilize your resources in a slightly different way.
Mm-hmm. That's terrific. That's congrats. I mean, that's terrific. So this is a question from Tara from Temple again. And I just wanted to mention this one, since it's you mentioned COVID, obviously top of everyone's minds right now. Have you adjusted any of your debriefing strategies? This question has come up a lot over our previous 2 webinars as well. So have you adjusted any of your debriefing strategies or goals with COVID specific patient codes?
No, we've just moved to Zoom.
Got it.
Do it on Zoom. So
probably same for everybody.
Yeah, instead of having, I will say that pre-COVID, we had gotten to a point where we could have probably filled an auditorium with the amount of people that were coming to the every Tuesday. So we were having to start looking for a bigger room. But now we have gone to obviously Zoom because we can't have that many people in one location. But it's always amazing when you see the nurses coming from the floors to present their own cases. They've worked through them, they've looked things up, because we want to back this up, right? And then to be able to tell them, you know, guys, you did a fantastic job. The pads were on the chest at the same time as you called the code. And I can see it. I can see the telemetry. I can see the patient losing their rhythm on the CPR feedback. I mean, the fact that you got the pads on before the patient even lost a rhythm is crazy.
It's impressive. Very impressive.
Good.
Yeah. Yeah, that really is. Wow. So, so I had a question on my mind. I'll come back to it. So, do you have a person or department who's solely responsible for gathering and summarizing the per unit and hospital-wide data? So essentially, do you have a data person, or is that data person you? And how does that all work?
Yeah, it's a lot of shared responsibility. So my job is actually as an advanced practice provider in the ICU. That is my job. We have a resuscitation coordinator who she works with the team, but most of her work is doing scheduling. We have automated a lot of things we've done on paper over the last 2 to 3 years. And so she does a lot of that busy day-to-day work. We have a performance improvement coordinator who is aligned with the resuscitation program. And so they're a nurse, but not a clinician who's practicing all the time. We have a physician who's over resuscitation. And of course, we all have another job, right? So this is nobody's full-time job. So we work really hard to try and work together. So like this afternoon, all those people I mentioned, the resuscitation coordinator, myself, the PI, our PI coordinator, our physician leader, and then directors and nurses from the units of the cases from this past week will all be on a call. And we keep track of a kind of a running to-do list of all the things that need to be done so we can escalate things to different places. And we use our occurrence retracking system to be able to also share that information. So everything is attached within our occurrence system. So our code reviews, our debriefs, these case reviews, we can attach them all. So that if somebody wants to go and investigate the case or do a root cause analysis later, they just pick up all that information from that central place.
That's terrific.
Record. Yeah, it's not the medical record, right? So we have all the information in the medical record, but this is kind of the review part. So things that you wouldn't put in a medical record.
That's great. Do you have, and you kind of answered this question already, Fiona, but just to dive a little deeper in it, do you have a dedicated code team where people don't have any other responsibilities on that day? It sounds like you don't, so they kind of have to move away from your regularly scheduled activities to respond to code.
No, we have a dedicated rapid response team, and they are responders for everything. It started off with one nurse on the day shift. We found that the off shifts were having codes, so we managed to make that a 24/7 one person. We then picked up all the other emergencies in the hospital, so stroke code, STEMI, PE, whatever other emergency you might have. They picked that up, so now we have 2 nurses 24/7 and a respiratory therapist, because we found that many of the codes were because of respiratory problems. So we have a respiratory therapist 7 days a week. They're not on the night shift. And then we use our critical care medicine team as our backup provider team. So they have jobs in the ICU, they have patients in the ICU. But if a code pager or overhead page goes off, they respond to that.
Got it. Interesting. A lot of hats people must wear these days, for sure. Many hats.
Yes.
So when you first started sharing all this, data that you were able to get from the codes, how did staff first perceive it? So what were some of their initial reactions? Positive, questioning it? Can you talk us through that process a little bit?
I think we didn't start directly with the CPR data. We just started with the code review tool. And I think we as the rapid response team started filling out a tool and then realized that we weren't the people that needed to be filling out the tool. So when you give it, when you give it to the people that were at present, that's their interest in reviewing their own cases. So it's not us giving them information, it's them finding their own information. So it's a subtle difference, but it's not, it's initiated by us in terms of the code happens and our PI coordinator sends out the code review tool just to say, hey guys, we need this filled out in 72 hours. But we just recently started sharing the data that I just showed you. And actually last week, one of our unit directors was like, this would have been great if we would have been able to give this to the staff right away, because they thought that they hadn't done a good job. And this would have showed them that they did a phenomenal job of getting on the patient. And so, you know, we're not perfect. We try and get things to the staff as fast as we can, but we don't always. So, you know, we've got opportunities there.
Oh, absolutely. And that's, I mean, that's great to hear, just kind of the positive side of it too, right? That encouragement of, yeah, I understand this was a hard situation, but look, you actually did do a really nice job. So that's great to have that objective data. So it's not just that, you know, I think you did good or we could have done better. You actually have the objective proof to say, no, you did a great job of getting the pet done.
Right, because it's not all about the mortality, because a lot of patients,
right.
We review and we actually give our patient, we actually review the codes, and as an interprofessional group, we say, what could we have done differently? So we give it a classification and then we give a preventability rating. So we actually rate our codes.
Wow, interesting.
And so then we collate that information so everybody gets a level of each one. So it's like a 1A or a 2B or a 3C or whatever, like however we rate them. And then we can pull that data because it's in a spreadsheet. And then actually I was able to give the information to our palliative care team, because what we found was that in a lot of situations, we should have never coded the patient to begin with, because they had a conversation prior to that. So that helped, you know, kind of with that piece.
That's very interesting. Yeah, that has to help many departments, I would think, make those calls beforehand. Interesting. Okay, so I have a question about how you're able to pull and what you do to pull the data off of the Zoll defib. Do you use is it all Wi-Fi, or how do you get the data from the defib?
It's an online program. So the first, when I showed you somewhere in the middle of the slide deck, there was a CPR mannequin. So that was code review, I think we called that. Again, that was
it was.
So that was a little bit more challenging, because you had to go dig and find the cases, and that was time consuming. So I actually was able to get a grant that helped me fund purchase of the case review, and that is like super awesome. So we can literally, I can go on from my house, we can share, everybody can be on at the same time, we can all go in whenever we need to. And literally, I think probably what we'll try and do 2021 is have our rapid response nurses pull it up after the code during the day. I think that's probably where we're trying to get to. The feasibility of that is, you know, when you actually have to do it in practice, maybe a little more challenging. So, but that's where we're headed to, is to pull it up that day.
That's terrific. Yeah, it sounds like you guys have made a ton of progress, and obviously more to come. That's fantastic. Do you use this data at all, and do you debrief at all? Do hot debriefs after simulations?
Yeah, I don't do it there, but I know that our education team does do that. So we've been restricted in a lot of our, in-person training this past year. Obviously, we couldn't train at all between February and June. We had no in-person training, but I know that they've been using it to in our sim center. We have a sim center, so that's where we train people generally.
Great. So that's the tools not only Oh, sorry. Didn't mean to interrupt you there.
No, I was just saying when we don't have COVID restrictions, so we're
Of
restricted
course.
10 or less
Oh, geez.
also, and that includes the instructor. So we've been restricted to that for most of this year.
So it's been a little more challenging lately.
So it's had to have been done, yeah, in person. That's really where we've done the Zoom and the, you've just tried to make the best of it. And then, you send it to the different groups. So have a physician group, have the nurse group. Everybody wants to, they get the same piece of information, but they want to look at it differently. So for example, one of the ones that I showed earlier, the doctors were like, did we really wait that long and do intubation when we should have been doing CPR? I said, well, you had opportunity to just, bag valve mask and defibrillate. That was your opportunity. And they identified it. They just didn't actually validate that until I showed them the strip.
Oh, okay. Interesting.
So they like that though, because they're very data-driven people.
Even better, more buy-in. That's terrific.
Yeah.
That's terrific. So your code review or your rating system has definitely generated some interest.
Oh, good.
We are. Someone is wondering. Diane is wondering if you'd be willing to share the rating system via email.
Yeah, actually, I can tell you where we got it from. It's actually from an article that's on sepsis, and so we kind of borrowed it from the idea from there and put it together. It's a work in progress, but that's where we really got it from. So I would I'll have to look at that article. It's by Ree, and it's about kind of mortality in sepsis, but that's where we got it from, if you want to look it up. But then we adapted it, and we're in the process of adapting it further. So, I mean, we can certainly share it, but I think that's a good way of cataloging, when you want to really catalog things.
Well, it makes it easier for you to find things. It just makes it so much easier to kind of look at the data in a different way. That's very
interesting. We're trying to see if we can build it into our recurrence system so it becomes, I'm all about getting rid of every piece of paper we have. So like, put everything in the computer we can put in the computer. But that's what that's kind of what we're working on now, is can we get it into a system so this is not on paper and getting lost somewhere. It's all in a very well protected system.
Which is great. Again, you can find it. How about that, right? Be able to find it and learn from it. That's terrific. So earlier in your presentation, you mentioned how the guidelines just came out just a little over a month ago. Do you anticipate any changes in practice resulting from those updates?
I don't think so. I don't know that the guidelines really changed a lot in terms of our care delivery. I think what I got most from the guidelines is where are our opportunities to improve and where should our research be targeted. And so it's interesting actually, because I was reviewing them because we're writing a paper on we've actually now 3 years out, and we've looked to see the impact of the rapid response team on unplanned admissions to the ICU, on cardiac arrest. And so we have statistically significant data in all of that now over a 3-year period. And so I think that helps answer some of the questions. So do I think that it changed a lot? No. Did it validate some of the things that we knew already? CPR is like the prime directive. Yes, it told us that. And then, where should we really be looking to improve and publish and so that other people can share and learn? That's what I think it told us the most, is we have evidence, and we really do, but we're not really good at writing it up and sharing it.
Right. Gotcha. Interesting. Thank you. So following up on that a little bit, this question is from Steve from IU Health. So this isn't necessarily about debriefing, but just to follow up on the guidelines question. Does your code response team only use AHA algorithms? I'm sure you've seen some services are publishing data, suggesting using different concepts. So what's your take on that?
Yeah, no, we've used a couple of different ones. We've used, we actually have been using another program, Advanced Resuscitation Training is what we've been using. And to be perfectly honest, that's what we were using up until COVID. But what I think we found was that the in-person training is obviously the most effective. Unfortunately, it's really hard to deploy in terms of people power, in terms of synchronous training. And so the regulatory part was what really got us into trouble, I think, with a different model, is that trying to keep up with the regulatory requirements is really, really difficult when you can't do classroom training. I think what we decided to do was we were going to use our AHA online training so that was our regulatory checks. And then we will supplement and train with code leadership training, rapid response training, primary prevention of cardiac arrest, kind of that, that chain of survival. We'd work on those pieces when we can have a little bit more in-depth time with that, or we can train in situ in the hospital because we don't have restrictions there on training. So that's that gentleman's question. Hopefully it does.
So it sure sounds like it. I mean, it sounds like everything COVID has really set us back, right, in terms of getting more training on these things, which of course you'd need just due to restrictions. So yes, thank you very much. A great question here. Have you been, kind of what we're all in this for, have you been able to increase your discharge rates, neurologically intact rates from in-hospital arrest?
So I would say that is something we still have to really define. I can tell you what I know to be true is that we get most of our cardiac arrests to the intensive care unit. So we have very few people that don't make it from the floor to the ICU. Now, most of the time, because these are inpatients we're talking about, those patients have so many comorbidities that a cardiac arrest does not really, they weren't well to begin with. And so a cardiac arrest didn't put them in a better place for the most part. So most of them end up with goals of care discussions, and then they have a peaceful death rather than another round of CPR until they don't survive. So I think it's hard to say because I think we've got other mechanisms that make a difference to the answer to that question, if that makes sense. Like, it's not just about did you survive to CPR or to discharge with full neurological recovery. A lot of these people didn't have full neurological function before the COVID.
Oh, I see. Right.
So that's a lot of slicing and dicing that I think we have to evaluate further.
Got it.
Able to answer that question with certainty.
Got it. Okay, thank you. I have, it looks like, just one more question to ask. Let me scroll back up here. So what are some, and you mentioned this in your closing slide, but if you could maybe add a little bit more. So what are some key takeaways that you can, give to the group here today on using debriefing to really improve overall clinical outcomes?
Teamwork. You got to have teamwork, and you've got to have a culture that is going to support that. And it's got to be non-threatening. So I think if you create that culture where people are expecting a debriefing versus it suddenly just happens and they weren't expecting it. And I think people have to be trained. They have to be trained to provide feedback. And so, just like everybody else, we have novice nurses, and it's all of our rapid responders are people that have at least a year plus, mostly more than that, but at least a year plus. But I think that we have some of the newer ones that they're still working through how to manage an emergency. And so we need to make sure that, we're training them to also, it's about the being on stage. So say, you can have a meltdown, or you can have, discussions later, but you are on stage and this is your role, and you need to be able to manage and calm the room.
Sure.
And so that's hard. That sounds easy to say, but it's not easy.
It doesn't sound easy. No, not at all, especially after an event, even if it's not right after, if it's pulled, if you're looking at all this data, which has so many people involved. Yeah, that's a lot to handle. So interesting. Well, Fiona, I think that's all the questions we have. So
Thank
anyone, we
you.
still do have some time. So if you guys have any other questions, please go ahead and enter it in the Q&A. I'm just going to give you another minute to do that. But while we're waiting, Fiona, I just wanted to personally thank you for your contributions to the Resuscitation Debriefing Masterclass. I do truly,
Thank you.
and we at Zoll do truly appreciate you joining us today. And again, to everyone on the call today, all of us at Zoll just really want to thank each and every one of you for continuing to, really put your own health at risk, to continue to help us and to save us, and your tireless efforts on the front lines of this pandemic. We really, truly hope you found today's session beneficial. We look forward to seeing you again on Thursday for our next and fourth session in the Resuscitation Masterclass session, or series, excuse me. So please do join us then. If there's no other questions, which it doesn't look like there are, Fiona, again, I just really want to thank you for your time. That was a terrific presentation today. I think it was a great Q&A, and hope everybody enjoyed it. So thanks again. Have a great afternoon, everyone. Thank you.
Bye-bye.
Bye-bye.